So today we'll be talking about if the standard of care has changed in the second line setting for relapsed refractory large cell lymphoma. This will dovetail with the presentation that Dr. Hamadani just gave. Sorry, things got stuck here. There are my disclosure slides. So as many of the audience know, diffuse large B-cell lymphoma is the most common non-Hodgkin lymphoma. It represents about a third of non-Hodgkin lymphomas diagnosed within the United States. Most patients present with rapidly enlarging lymph nodes or B symptoms. Some patients present asymptomatically, but the B symptoms are classically unintended weight loss, fevers, and night sweats. There may be predisposing factors such as history of lymphoma within the family or an immune-compromised clinical situation, but most of the cases have no previously identified predisposition. In terms of epidemiology of non-Hodgkin lymphoma in Saudi Arabia, 6 out of 100,000 age-adjusted incidents within the population, and that results in 4 in 100,000 age-adjusted mortality. 55% of the diagnoses are advanced age, which is common also in the United States. What's unique to the Saudi Arabia population is that there's a high incidence of hematologic malignancies relative to the West. Patients present later and with worse prognostic features, and this has been reported. There's an overall younger patient population. There's been a heavy investment in healthcare to overcome health inequality. And there's a need, or a large unmet need, for potentially curative treatment options within the Saudi Arabia population. So for newly diagnosed diffuse large B-cell lymphoma, R-CHOP or R-CHOP-like chemotherapy is a standard treatment. But a certain fraction have refractory disease or relapse disease after the first line of therapy. The majority of patients in the modern era achieve a complete response, but again, depending on risk, predefined prognostic factors such as IPI, as well as biologic factors such as double hit or double expressor biology, there are a real fraction of patients that will have either relapsed or primary chemotherapy refractory disease. In the modern era, at least 60% of patients are cured with first-line chemotherapy. In the relapse refractory setting, the standard of care for nearly 30 years has been dictated by the PARMA study, which was conducted in the mid-1990s, or reported in the mid-1990s, wherein patients in the relapse refractory setting received platinum-based salvage chemotherapy with DHAP. And for those that achieved a chemotherapy-sensitive remission, they were randomized to high-dose chemotherapy followed by bone marrow transplantation, or conventional chemotherapy, meaning continuation of the DHAP. And as you can see, there was a statistically significant improvement in overall survival in this prospective study that randomized just over 100 subjects. What's the historic outlook for patients that failed at least 2 lines of therapy, meaning those that were unable to achieve a remission in the relapse refractory setting or relapse following autologous transplant, or were ineligible for such aggressive therapies? The Scholar retrospective data set of over 600 patients has defined this patient population. There are certain caveats to this group, with a median overall survival of 6 months. These are non-clinical trial patients. So these are patients that were registered in the practice community amongst a bunch of United States, or actually North American centers, and reported in terms of progression-free and overall survival. So with those data, the ZUMA-1 study investigating ixacabtagene ciloleucel in patients with relapsed or refractory aggressive B-cell lymphoma was conducted. This was a multi-center, single-arm phase 1/2 study following a median of 3 lines of prior therapy. As you can see, greater than half the patients achieved a complete response, and the vast majority of patients had an overall response. As the Kaplan-Meier curve demonstrates, and importantly and qualitatively, the median overall survival was 25 months, but there clearly appears to be an inflection point and a plateau on the curve. So in 2022, we can confidently say that this therapy can be approached with the intent of cure. As of the 5-year cutoff data, there have been no new safety events, but as we are now familiar with a CD28 co-stimulatory car-modified T-cell product, there is a relatively high incidence of toxicities, including cytokine release syndrome in nearly all the patients, the vast majority being mild to moderate, grade 1, 2, but a real incidence of grade 3 to 4 immune cell-associated neurologic toxicity, or what we now call ICANS. And you can see on Zuma 1 that approached 31% cumulative incidence, grade 3, 4. The Transcend study is a second study, single-arm phase 1 with a car-modified T-cell product, lysocabtagene maraleucel, that subsequently garnered FDA approval in the United States. This product has a variance of difference in that it's a 4-1BB co-stimulatory molecule as the secondary co-stimulatory molecule for the car-modified T-cell product. As you can see, very similar response rates to the Zuma 1 study. The overall survival at median follow-up of just over 2 years. The median overall survival was 27 months. And again, there appears to be some appreciation of a plateau on the Kaplan-Meier curve, although some late events have been noted. The safety profile is somewhat different to the CD28 co-stimulatory axicabtagene ciloleucel, wherein less than half the patients actually experience CRS, and severe grade 3 or 4 neurologic toxicity is less common, and incidence of 10% related relative to the 30+% with axicabtagene ciloleucel. The last single-arm phase 2 study was the Gilead study testing tisagenlecleucel, which was developed at the University of Pennsylvania for early relapse refractory DLBCL. Again, median lines, 3 prior lines of therapy. The vast majority of patients were failure following second-line therapy. Somewhat more of a modest overall response, with less than half of the patients achieving complete response and just over 50% of the patients having an overall response. These responses were consistent across all prognostic subgroups. The median overall survival on the prospective phase 2 study was 11.1 months, with, again, an appreciation of a flattening or plateau of the Kaplan-Meier curve, thus speaking to the potential of this therapy to be delivered with curative intent. Similar to the other 4-1BB co-stimulatory product, lysocabtagene maraleucel, tisagenlecleucel demonstrated relatively favorable safety profile, with just over the half the patients experiencing CRS and a minority experiencing severe grade 3 to 4, with rare severe grade 3 to 4 neurologic toxicity events, again, similar to lysocabtagene maraleucel at 11%. So in the first relapse refractory setting, this is a schematic that demonstrates the natural history of this process. I would say at most academic centers, transplant intention is in the majority of the patients, despite age or comorbidity. But even in transplant eligible patients, less than half of those patients make it to transplant, because we know in the modern era that platinum-containing salvage programs achieve an adequate remission of at least a partial remission or complete remission in likely less than half of the patients. And for those patients that proceed on to transplantation, at least 50% of them will experience progression of disease. So if you take 100% of the patients across the treatment continuum, transplantation within this schematic is estimated about a curability of about 10%. I would argue that prospective studies would place that figure more in the 17 to 25% range, depending on risk at time of relapse. But be that as it may, the vast majority of patients are incurable with standard of care second-line therapy. As you can see here, many of the outcomes of patients that have proceeded to transplant remain poor, as I previously highlighted in the other slide. This is a retrospective real-world analysis of patients treated with R-GemOx, which is considered an outpatient program in the United States, at 2 French centers, with clearly inferior long-term progression-free and overall survival data. So there are a number of needs and patient groups that have been identified, particularly in the phase 3 studies that I will mention here. Patients that either have primary refractory disease or early relapse disease have been identified as a high-risk patient population for previous contemporary salvage studies like the CORAL study that tested rice versus RDHAP. And there are also a number of patients that are ineligible for intention to go to transplantation, either based on age, comorbidity. I would say, moreover, disease biology tends to dictate that. The ZUMA-7 is a randomized phase 3 study of axicabtagene ciloleucel in the second line versus standard of care platinum-based salvage chemotherapy. In this study, high-risk patients were identified by either primary refractory disease or relapse less than 12 months from first-line therapy. They had to be transplant eligible based on performance status, age, and comorbidity. And then patients were randomized between the CAR-modified T-cell product and standard of care. Important study conduct on this study is that investigators determined chemotherapy sensitivity in the standard of care arm. Responders then were intended to proceed to high-dose chemotherapy followed by autologous transplant. And in the axi-cel arm, no bridging therapy outside of steroids were allowed. The median turnaround time for the product was 17 days, which was 19 days in Europe and 16 days in the United States in this multi-center international study. Here are the disease characteristics of the patients treated on study, with the vast majority being primary refractory to initial induction chemotherapy, meaning never achieving a complete response to initial induction therapy. 26% had relapse disease less than 12 months from primary therapy, and then 17% of the patients had high-grade B-cell lymphoma by most contemporary WHO criteria. So this is the Kaplan-Meier curve towards primary endpoint of event-free survival. You can tell there was a statistically significant increase in event-free survival at a median follow-up of 2 years, which I would consider very adequate, and a hazard ratio of 0.4 favoring axi-cel over previous standard of care. As you can see, there are plateaus on both of these curves, and at 2 years, 41% of the axi-cel patients remain event-free on study, wherein in the standard of care arm, 60% remain event-free. For the forest plot, there were no significant prognostic factors that favored axi-cel, that favored standard of care over axi-cel. So this result was consistent across all prognostic subtypes, including based on age, primary refractory or early relapse disease, higher or lower risk based on secondary age-adjusted IPI, which was a stratification standard or factor on the study, and then the 2 histologic subtypes. Here's best response per standard of care in axi-cel. As you can see, a superior overall response rate of 83%, which is somewhat expected with this therapy, versus 50% overall response rate, which I would believe to be consistent in the modern era for standard of care. Importantly, there was no overall survival benefit demonstrated at the time of publication for this study, but over 50% of the standard of care patients eventually went on to receive subsequent cellular immunotherapy, not per standardized or protocol dictated crossover on study, but just once an event was determined, they went on to receive commercial product. Here are some of the AEs, most notably consistent AEs based on cytopenias, consistent grade 3 AEs. Neurologic events, not surprisingly, were much more common in the axi-cel arm, given the unique immune cell-associated neurotoxicity seen with CAR T cells. There were no incidents of grade 5 CRS reported on axi-cel, and no grade 5 events reported with axi-cel or standard of care. These safety profiles were consistent across the age subgroup stratification at 65 years of age or older. The TRANSFORM study was the second randomized phase 3 study, very similar to ZUMA-7, and this is testing the lisocabtagene maraleucel product. There are some small caveat differences. It essentially enrolled the same patient population, defining high risk by primary refractory disease or relapse less than 12 months from first-line therapy. Patients had to be eligible for transplant. At the time of enrollment, patients underwent leukapheresis, which is a variation from the ZUMA-7 study. There was then a randomization between standard of care and investigational lysocell. An important difference with the ZUMA-7 study is that bridging therapy was allowed on the clinical trial, and then lysocell was administered per trial conduct. Response assessment was following the institution of the lysocell, as well as completion of standard of care platinum-containing salvage therapy. The primary endpoint was event-free survival, which was met. The median event-free survival in standard of care was 2.3 months compared to 10.1 months in the lysocell arm. This was met with a hazard ratio of 3.35 and a very significant p-value less than 0.0001. As you can see, the safety related to lysocell on the right-hand column, consistent with the previous Transcend study. Any grade of CRS was observed in less than half the patients. There was very few severe neurologic events, grade 3 or greater, and that was observed in 4% of the patients. And safety was considered consistent with the previous lysocell Transcend study, as noted on the slide. The third randomized phase 3 study was deemed to be a negative study. This was tisagenlecleucel, randomized again against standard of care, very similar study design. Some of the potential reasons that this was a negative study is that there was a significantly prolonged time from apheresis to actual infusion of greater than 6 weeks with a delayed manufacturing process. Despite that, the overall response rate at first disease assessment with the T-cell arm versus standard of care was similar. And as you can see, the event-free survival between the two arms was equivocal. Thus, this was deemed a negative study based on the primary endpoint of event-free survival. There were important caveats in this study that were different, most notably that patients on the standard of care arm were essentially mandated to second salvage before deeming failure in the standard of care arm. So if a CR or PR wasn't achieved, a patient had to go to another line of therapy, either non-cross resistant platinum or other platinum per investigator choice. So currently the NCCN guidelines reflect that in the appropriate patient population of primary refractory disease or relapse less than 12 months from primary therapy in large B-cell lymphoma, FDA approval of both axicabtagene ciloleucel and lisocabtagene maraleucel has garnered NCCN guidance as a standard of care, at least per the purview of the NCCN. And in summary, I would like to say that obviously those two products are approved. I think in reflection and through the lens of Dr. Hamadani's last talk, not every patient is the same and fits the same mold. I personally believe that there still is a role for autologous transplant, particularly within consideration for patients that had a complete metabolic response to initial primary induction therapy but had early relapse. I don't think we've explored novelty or novel therapies around salvage chemotherapy as well as the transplant. Be that as it may, this is now a standard of care to approach patients with either axicabtagene ciloleucel or lisocabtagene maraleucel in the second line for those that met protocol criteria. That's reflected in the recent phase 3 studies as noted in the third bullet point. There were no safety concerns in the second line above what was studied in the previous single-arm third-line studies. And I believe that CAR T-cell does represent a new standard of care, not the standard of care, including in the second-line relapse refractory large B-cell lymphoma as highlighted by the newly updated NCCN guidance. So with that, I would like to thank you all for your attention and be happy to take any questions.